Good afternoon, everyone. Hi, everyone. Brian Lewis here from KidneyCAN, back again for another joint edition of the National Kidney Foundation's Facebook Live series. For today's discussion, we're going to take a look at some of the things you'll want to know after you complete your kidney cancer treatment. The theme today is survivorship. Today, we're lucky to be joined by Sue Burke. Sue's a certified oncology nurse who spent over 30 years in the field of cancer treatment. And Sue joins us today from Fox Chase Cancer Center in Philadelphia. Sue, welcome to the show.
Thank you, Brian. Thank you for having me. It's a pleasure.
Great. We're looking forward to hearing some of your insights. Also with us today is a kidney cancer patient survivor, Howard McClurd. And Howard was treated about 18 years ago, and he's been gracious enough to come on the show today to share his experience as a cancer survivor. Welcome, Howard.
Thank you, Brian. Thank you for having me today. And thank you for all our sponsors that allow us to be here to help the other kidney cancer survivors.
Great, great. Looking forward to diving into some of these topics. So right off the bat, Sue, define survivorship for us. Is it when you first get diagnosed? Is it when you finish your treatment? What do you think?
I personally think it's from the minute that you're diagnosed. I know some people feel that it's after you're finished everything and you're surviving, but I think every day from the day of diagnosis going forward is survivorship, one day at a time for surviving.
There you go. There you go. How about you, Howard? You must have an opinion on this.
Oh yeah, my survivorship started from the moment that I was told that I had RCC, which at that point, it was devastating. So I think from that you're planning your journey.
Got it. And so Sue, one of the things I remember, early on after diagnosis, a lot of new language, a lot of new lexicon that comes at you for cancer, your cancer diagnosis. Can you tell us about some of those things like NED or CR, some other acronyms that are out there?
Sure. First, as a medical professional, I think we start in layman's terminology, but cross over in our explanation. Important thing is if you find that happening, I would tell you just to tell the physician or the nurse not to be embarrassed, but can you bring it down a level, or can you explain what that means? But some of the big acronyms are CR, clinical response. If you're getting treatment and they do a scan and they see that your tumor is either shrinking or it's gone, that is considered a clinical response. NED is no evidence of disease. And what that is, when everything's finished, either your surgery, your systemic treatment, and you're being followed with your scans, CAT scans, MRI, ultrasound, and every one comes back and there's nothing there, that is considered NED, no evidence of disease. So I think that's probably the one you're going to want to hear the most, NED.
Absolutely.
Yeah, so Howard, you're NED now, so tell us a little bit about the language and learning some of the things that you had to learn.
Well, I had a little bit of an advantage of most people. At the time, 18 years ago, I was selling medical supplies. So, and fortunately or unfortunately, I was in the urology world. I was a catheter salesman, okay? I had a small company that later grew to very large, but for me, I kind of knew a lot of the lingo. Even that being said, when you're diagnosed with it and those acronyms get thrown at you, you start analyzing it. When, like I said, the doc said, this is renal cell carcinoma. And I just thought back and I had literally started laughing. I'm like, you can't be talking to me. I'm in the best health of my life. I run, I work out, I'm a gym rat. I can't believe it. With that being said, that RCC, when he started saying it, I'm like, renal cell carcinoma, that's kidney cancer. It was hard to digest. So these acronyms, are very important, and you do need to ask the questions. So even if you're a medical professional, when you get hit with this, you become a little dumbfounded, to be honest with you. So it's really, yeah, as a patient, you become the patient, not the medical professional anymore.
Got it. That's great insight. So one of the things I think we all know about is scanning and follow-up scans. That becomes a part of your new life. Sue, why don't you just tell us a little bit about the scanning process for someone, maybe some of your standard, if there are standard types of cases.
So a lot of the scanning is based on your pathology, the size of the tumor, the grade, different things. And what we do is we follow the NCCN guidelines. So there's actually a icon, I guess is the best way of saying, where we feed the information from that patient's history, from their pathology, the size of the tumor and whatnot. And based on that is what your follow-up scans are. And some people will say, well, why are you only doing a chest x-ray or a chest CAT scan on me and not my abdomen where my kidneys are? We follow their guidelines, and the first place usually kidney cancer goes to is the lungs. So that's why we also look at the chest, but that's what we follow. And you know, that's how we determine who patients follow up.
So how about you, Howard? You must have had some scans in your 18 years?
Absolutely. Back 18 years ago, it was a lot more common to do multiple CAT scans. I did bone scans, CAT scans. These were done on a regular basis. Now I believe, and Sue, you can maybe comment on this, but I think that's been dialed back because of the amount of radiation that you get. But prior to, and of course, afterwards, the surgery that I had, it was every 3 months for the first couple of years. So it really, like, I think that the projection of now versus then, in retrospect, is to minimize that radiation. So
correct. And it's based also on your stage 1 versus stage 4. Obviously, stage 4 is going to be followed more closely, hence the NCCN guidelines. But we definitely have dialed back on the CAT scans and the dye, switching more to ultrasounds where there's less radiation and whatnot. Correct. Yep.
Now I've noticed that, obviously through the years, it's been going more ultrasound, more blood work, more chest x-ray, lighter technology, less radiation. So it's, looking ahead, that's what you want to do.
Correct.
So let me jump in here, Sue. You use the word pathology. So pathology is the study of your actual tumor site? Correct.
The actual tissue, tumor tissue. Goes to, so if you're going to have a partial part of the kidney taken out or all of the kidney, that obviously all goes to pathology to be tested. A lot that has come forward in the years since Howard probably has been diagnosed as something called active surveillance, where some people have something on their kidney, and due to other comorbidities, meaning heart disease, strokes, things like that, or their age, we biopsy the kidneys now, not the kidney itself, the tumor on the kidney, and see what grade it is and what it is. And if it can stay on active surveillance, that's what we do. Obviously, we follow them a little bit more closely because it is active surveillance. And once it starts growing, then we need to make a decision. So that's the pathology. I always say the pudding is in the pathology. so that we are dealing with.
So that may have been an area that has been some area of discussion, at least in the patient community and maybe the medical community, is this active surveillance versus, biopsy versus active treatment. I know, simplistically from a patient standpoint, it's get that thing out of me as fast as possible. That's the mindset. And so when you throw out the phrase active surveillance, some people react probably differently than others. What do you say?
I think our physicians give patients all of their options, and that now is an option. So we would do anybody a disservice just thinking, like you just said, just get it out. Because I definitely do have patients that say, just get it out. I don't want to deal with it. But there are some people who aren't in a rush to go to surgery because of worrying what's going to happen while they're in the operating room or after the operation, and they're okay with doing active surveillance. It's usually a little bit of an elderly population, but it's there now, and it's an option that we can now give our patients. Not all of our patients, some of our patients. You have to fall within the guidelines. So, a lot of people think I have patients that come in, they say, get it out, I want it out, and then this is presented to them, and it's, I never thought about that, and they go home and they think about it, and they'll say, well, let's try one scan in 3 months and see what happens, and then we go from there.
And I think that's true because one of the things I learned is that many times, if not most of the time, these tumors are not growing at a rapid pace. Is that a fair statement?
Pretty fair. And they're usually found incidentally. The one thing I want patients to know, or anybody in the public to know, is, a lot of times it's, they had an accident, a motor vehicle accident, or they were being worked up for GI problems, or colon issues, and they do a scan, or if they had kidney stones, they do a scan and they find the mass, and they're like, I would have never even known it was there. That's usually how it's found. Howard, I don't know if yours was an incidental find or if you had blood in the urine, but usually that's rare that it's the blood in the urine. We usually find it sooner than that, but I just want people to know that they're not doing anything wrong. They didn't ignore anything. It's usually incidentally found.
Yeah, I was one of those people that had pain, which is fairly rare, and unfortunately, I did ignore a lot. Again, self-diagnosing, which so many people do. I had low back pain. Again, I thought I was just a little disc issue, that kind of stuff from working out, the gym. I had been in a minor car accident prior to, but it was no big deal. But I had flank pain, so the back pain turned into flank pain. And I was actually going to get on a plane over the weekend, and I drove myself in the emergency room thinking I was going to have appendicitis. And then they found a mass on my kidney. So as I followed up and found out what it was, of course, then that real journey started happening. And speaking of your pathology, conversation, for me, finding out that I had a rare form of what's called chromophobe, it kind of also enlightened me and the physician, after the surgery of what to do. So in those cases, you need to know your pathology and know the recurrence rates and things like that, so that you know what to do. So that's very informative.
Let me touch on a couple of things and pick up, Sue, where you want to. So generally speaking, a lot of scans take place during the first 3 months after you've been diagnosed or after treatment. Sometimes you then can graduate to 6 months and then to even a year, and about a year out as annual scans is about the standard. Is that a fair statement?
It's fair. It's not in stone, because like I said, a lot of the scanning is based on the pathology and the stage and the grade and whatnot and the size of the tumor. But it's usually, some people's first scan out is 6 months, like I said, based on what they had, the pathology. But that's general, I would say, yes.
Okay, so generally speaking, speak to your medical provider about specifics of your case, of course. So let's talk a little bit about, Howard. You've got scans coming up maybe sometime in the next several months. As it leads up, what's your mindset? What's your thought process? Because I know there's this phrase out there, scanxiety.
That's a good coined phrase, because I think almost everybody would have some of the real anxiety associated with the scanning. Every time you go get a scan, you think, okay, is it going to come back? With basically about a 40% reoccurrence rate in kidney cancer, it's pretty high. So, for most of us, they're always in the back of your head. You try to stay positive, straight positive. I mean, that to me has been the driving light from the moment that I got diagnosed was, this is not going to take over my life. I'm not going to be the patient. I'm just going to be a person with an issue that, it's going to be a new normal for me. But the scanning part has always been and will be continuously for the rest of my life, be an issue. I've also had, that word cancer said to me a couple more times since the first initial diagnosis. So it wasn't kidney cancer, but it was other cancers that I had to deal with. So, it's always going to be there, and you're always thinking, when's it going to pop up its head? So for us, we always are going to deal with that anxiety for it. It's the minimizing of not letting it affect and kind of drive your life is the most important thing.
So on this note, Sue, of scans, and I know we don't have a lot of time to dive into the weeds, but there's CAT scans, CT scans, there's MRIs, there's ultrasounds, there's PET scans, there's bone scans. Real quickly, could you tell the folks what are the standard ones that they should be keeping an eye out for? Anything around, the solutions you have to take in advance?
So usually I would say your CAT scans and your MRIs are the two that would identify the size of the tumor, if there is one there, picking it up a lot better, for lack of a better word. They're the two scans that I think would be the CAT scan and the MRI. I think your ultrasounds are, initially a doctor will order an ultrasound because we always start with the lowest and then work our way up for a more clearer picture of what the tumor is. But then afterwards for Survivor, as Howard said earlier, the longer you go out in survivorship, we switch to ultrasounds instead of CAT scans because of the radiation. But I think in the heart of it, it's the CAT scan and the MRI. And then slowly but surely it goes less and less.
And all of us.
One thing that Howard said, just because I just don't want to forget this, Howard has a great attitude. You could just tell the first time I met him, I just knew it. We're not all born that way. We're all born a little differently with different coping measures and coping strategies. I just want everybody out there that is going through this. It's number one, it's your journey. So I always tell everybody, you can't listen to everybody else. It's your journey. It's what you're going through. But there's always somebody available to help you with that journey, via a social worker, a psychologist, a psychiatrist, your clergyman, if that's who you want to turn to. But I don't want you to think just because you don't have that personality that Howard has, that there's still other ways to help you get through this if you need help. And it's always just a question of away or a request away. Just, I wanted to make sure I touched on that. Sorry, I went off the line there.
Thank you, Sue.
Yeah, that's a great point. I think it segues to another conversation, which is around your caregivers and those that are involved in your care team. Howard, you want to tell us a little bit about your journey? Who was there with you? What did you do? How did you get them involved?
Well,
what was their role?
Yeah, basically, your caregiver community starts to grow, and I mean, it did for me. Obviously, having a significant one at home and loved one, wife and family, that kind of stuff is invaluable. That person, of course, is the person you lean on the most through your journey. But it expands. I mean, for me, I was in business. After my surgery, I'm one of these people that has always been pretty much a workaholic, you might say. 10, 12-hour days were kind of normal. And after 10 days, my surgery, I'm like, come pick me up. I can't drive, but I got to get out of the house. I'm going crazy. An idle mind for me was the worst enemy. So for me to be active and busy and doing things, interacting with other people on a normal basis was a lifeline for me. But your caregiver community, it grows when your friends and family, is everybody has to be a part of it. So
Sue, this is a hypothetical. Do you ever have patients that come in by themselves, and what kind of advice would you give them if you did?
Yeah, as a matter of fact, I have one patient that we just did surgery on, and I said, you're going to need somebody to pick you up after the procedure. And he says, well, I don't have anyone. And I said, no one, like not a friend, because they won't let you go home via a cab or Uber because the person needs to be responsible for you. And he says, I don't have anybody. So, right away, I get social work involved, and, one thing leads to another. Now he has a support group, but they're not here in the Philadelphia area. They're in another state. So, he uses them to lean on him, but he didn't have anybody here to be with him. We have people who have very large families, but are very much alone, which is sad. And because of COVID, and I know we were going to touch on that a little bit, all of our patients that are coming in alone, and we're calling their family members from the office. They're either in the car waiting for them or at home. But I tell them that we're here, and, people hear the word social work and they think there's nothing wrong with me. I make a living and I work and I have a house, and I say, but that's not what social work is. They're there for you to help you, find ways to go forward in this journey. And I have them just promise me that they'll talk to them one time. I say, just one time, I want you to speak to them. And then after that, if you don't want to, I'm okay with that. Then it's your choice. Because I want them to really know what the social work department is here. And we also have a great pastoral care here too. It's cut back a little bit on the cutbacks from a couple years, but we have 2 great chaplains here who are awesome as well. So, I'm fortunate to work in a place that has that to our patients. But it's identifying it, and as a healthcare worker, I just think put yourself in that patient's place, and everything will just fall in for you to be able to help this person.
Perfect. Okay. Well,
Brian,
I'm going to.
Brian, can I quickly just
Yep.
add on to that? Part of the survivorship and going through this, of course, is your friends and family, but looking for information, like KidneyCAN associations, and your local hospital being a buddy system, that was invaluable to me too. So I connected through the hospital that I was going through at the time, and they did have a buddy system, and I actually talked to somebody that had gone through this. So there are resources, and now more than ever that they're available. So hopefully now through the internet, through obviously social work and the hospitals themselves, and patients that have gone through this, we'll reach out and our lifeline for you.
We do
Great
have
point.
that patient. Yeah.
Yeah, great point. And I'm going to put in a plug for an online community called Smart Patients, smartpatients.com. Great opportunity to if you're a kidney cancer patient survivor, to go out and register with them. And it's a private community. You have to be invited to be in. So you have to go through a process. So it's not just a public discourse. It's very targeted information. On that note, though, I'm getting the high sign that we need to take some questions from our audience. And so I want to shift gears here a little bit. I'll remind you folks on the Facebook Live, please feel free to post your questions in the comments section, and we'll do our best to answer them today if we can. If we can't, if we run out of time, come back to the National Kidney Foundation or KidneyCAN's Facebook pages, and we'll have answers hopefully posted real soon. So on the COVID-19, it looks like we got a question around, with telemedicine these days, and I'm just going to summarize this question. With telemedicine these days, can you talk a little bit about how COVID-19 has impacted patient care and follow-up? So I guess that's Sue, that's probably you.
Probably. So I think the first wave of COVID that we had, this was all very new to all of us. And the last thing we wanted to do was jeopardize our patients. A lot of patients are immunocompromised, but we are also aware that cancer can't wait either. So the patients that we could push some of the procedures back a couple months, we did, but it did not hinder patients that needed to go to surgery. We still had surgery going on. We COVID tested everybody 48 hours before they came in, patients. And, if a patient was uncomfortable going to a facility to be scanned, we, respected their wishes and then pushed it back a couple weeks. This second wave of COVID, I think people have relaxed a little bit, and people are like, I don't care, I'm just going in, I want to get my scan, and we're doing it that way. And then as for them notifying, all of their appointments are still the same, only we're calling them instead of them coming in. So that hasn't changed whatsoever. So I think we're going back. I think there was a little lull in diagnoses and new patients, because I think even family practices weren't sending patients to get scans. But once they were and patients felt comfortable, we did send them for their scans.
Got it. So let me see if there's another question here. All right. Question around evaluating websites and legitimacy. So Sue, I guess, again, you referenced the NCCN guidelines and the patient guideline information, as well as, and maybe Howard, you could follow up after Sue answers regarding websites. So tell us a little bit about the NCCN.
So that's the National Cancer Institute, and we're actually, we fall under their doctrine because we can do protocols and whatnot because we are part of them. That's one of them. Obviously, the Kidney Foundation is another one. A lot of it is based on what our physicians tell our patients, and we give patients brochures on these different, be it kidney cancer, bladder cancer, prostate cancer. We give them books when they come in, and whatever website is in the books, we've gone through it and we agree that the patient can go on there. So when in doubt, I would say ask your physician what is the one you should be going on, because just know they're the ones that are being policed and really watched by the medical community.
Got it. Howard, any thoughts on that?
As you mentioned, Smart Patients has definitely been a growing community that I think that people can rely on to get some actual personal experience on what's going on in people's struggles that they can relate to. Obviously, KidneyCAN is also a nice resource. Your normal things, I think that people are familiar with, National Cancer Society, these kind of things are going to have some general information, but look at the reliability of that organization and make sure you're just not getting your information from somebody just doing a blog. So.
Great. Let me shift gears a little bit here, Howard. So, and Sue, you can follow on too, going back to work, I think that's, or going back to your normal, if we call it
new
that.
normal.
Tell us a little bit about that. Reflect on that if you could. You mentioned that you wanted someone to pick you up right away after 10 days. So that's a little hint on where this is going.
I did. I definitely was very fortunate. My business partner would come and get me and pick me up and bring me into the office, and he'd be like, "You sure? You sure? You sure?" And basically for me, that mental diversion was a very positive thing. So getting back to work as soon as I could helped in my recovery. I mean, it really did. So for me, it's that action of reaction, dealing with the normalcy of day-to-day life. Now, it's the new normal. Of course, your life is turned around, upside down, whatever. But at least there was a portion of my life that was normal. So I needed that, and I think it's a valuable tool for most people.
So Sue, tell us some of the common questions and sending people back to their new normal.
Well, I think the first question anybody asks me after their surgery is, when can I drive? I think that is the number one question for everybody, because as my dad used to say, he'd hit his dashboard and he would say, "This is freedom," meaning driving, being able to drive yourself. So, everybody's a little different. Like I said, Howard is probably the type A, the one that I have to say, you need to, recover first, make sure things heal. But I agree that having as much normal into your life, like I will say to somebody, you can fold the clothes, you can't carry the clothes, you can dust, you can't vacuum, because you don't want to lifting anything heavy. But I really truly believe that normalcy helps you, brings you back into it. It's a new norm, but at least it's a norm. And when I tell people to take a walk, I say, and I don't count walking around the dining room table 4 times. You have to go outside and get fresh air, even if it's walking to your mailbox and back, because getting out of those 4 walls, you do nothing but think. And I think, Howard, you probably know that. And it really plays some tricks on your mind and also slow down the healing process.
So we're going to stick with this going back to work theme, but also want to touch on some of these emotional, mental challenges or issues that are going on. So Sue, can you dive in a little bit on, the Family Medical Leave Act and what it means in terms of disability, those kinds of issues?
Sure. So I always tell my patients there's 2 things they need to do before their surgery. There's number one, if they have short-term disability, and that's what gets you your paycheck, your short-term disability. Most companies have it. Some people have own their own businesses, which is a little bit more difficult. And then there's FMLA, which is the Family Medical Leave Act. And what that does is that guarantees your position for 12 weeks a year with your company so that they can't replace you. Like, so someone can't replace me permanently with the doctors I work with for 12 weeks. They can, after 12 weeks, move you around in the hospital, we're going to say, since we're talking about a nurse. But it guarantees your position. It has nothing to do with money. It's just about your position. So I always tell my patients to get both sets of paperwork, your FMLA and your disability. I have to say most of our patients go back within a 12-week period, especially with robotics out there. Depending upon what they do, if you're a desk worker and you sit behind a desk, most people want to go back within, 2 weeks, 3 weeks. But if you're a heavy cranes operator and you're doing heavy lifting, we usually give you 8 to 12 weeks because we want everything to heal, especially if it was a partial kidney removal. We want everything to heal inside. So there are the two big things I would say for disability and FMLA, to make sure you get 2 sets of papers, and that's from your HR, your human resources would give you that stuff.
Great, great. Well, lots of great stuff here. And I know we just started scratching the surface, but I can't believe the time has flown by like this, and we've got to wrap up. And folks on the Facebook Live, if you didn't get your question answered today, please just be patient and feel free to post it again. We'll make sure to answer those either at the KidneyCAN Facebook page or at the National Kidney Foundation's Facebook page. We really want to again say thank you to our sponsors. We couldn't do this without your support. The patient community appreciates it. And I'd especially like to thank Sue and Howard for these valuable insights. Sue, thank you very much for this valuable information.
Thank you, Brian. Thank you for what you do for the kidney community.
You bet. You bet. Howard, thank you so much. Appreciate you sharing your story.
Thank you. I appreciate it very, very much, and having the opportunity. And, please stay positive, and survivors, please get active. We're always looking for more people to help other people. Obviously, look at KidneyCAN. The National Kidney Cancer field is growing, so more and more of us patients are being survivors. So every little bit and every voice counts.
Yeah, there is a national organization of a coalition of survivorship out there if you are interested in further information too. And I heard a statistic that there are now 15 million cancer survivors in the United States, which is an astounding number. So it's a new and exciting fact to share with you all. I'd like to just say thanks on behalf of KidneyCAN. Thank you on behalf of the National Kidney Foundation. Folks out there, please keep washing your hands, keep social distancing, wear your masks, have a great holiday season, and looking forward to 2021 with those vaccines, I hope. Take care, everybody. Best of health.
Happy and healthy.